All right, so due to the limited of time, so I would like to invite my colleague from Indonesia, Dr. Dafta Hajusar. Dr. Dafta will talk about bifurcation in stent restenosis. Please, Daf.
Thank you, Dr. Donny, and thank you for having me. Well, my slide, please. Okay, I think there's a bit miscommunication, and my WhatsApp got hacked 2 weeks ago, so I thought I was supposed to talk on standard stenosis in left main bifurcation. So this is what I prepare. Hopefully, we can learn something from this. So as introduction in de novo lesion, I think we know that as times go from POBA to DS, second generation, the restenosis I think decreased to 5 to 10%. And then in left main bifurcation, stenting is I think the restenosis rate is between 1% to 19%, and target lesion revascularization between 2 to 16%. This is by definition, we usually use two definition, angiographic ESR, which is greater than 50% restenosis in the vessel and stented segment and 5 millimeter proximal distal to stent. And for clinical in-stent restenosis is stenosis 50% greater than 50% without plus plus symptom, or greater than 70% with no symptom. I think from the previous RCT, we learned that the most site, regardless of the left main stenting strategy used, either one stent strategy or two stent strategy, I think the most part that get restenosis is the ostial circumflex, as is shown there from the sub-analysis and the EBC main. And then we also know from the study, non-left main study, that angioplasty with the paclitaxel coating balloon and repeat DES in ESR, actually DES is better due to the target lesion revascularization. But there is in the sub-analysis, you can see that the balloon coated, drug-coated balloon is better in focal ESR and also in BMS. If we look at the DEB, then DES in the in-stent restenosis, which in large cohort analysis, the bifurcation lesion, I think in population is regarding, it's about DES is 12% and DEB is 15.7%. So it's very small number actually involve bifurcation. But here you can see that the MACE is in 1 year, it's actually greater in balloon. So, and then as it goes on, it shows that DES is better for in-stent stenosis. But if we do a Cox regression, we actually look at at 1 year and 3 years. Actually, if we do a Cox regression between DEB and DES at both 1 and 3 years, there's actually no difference. The one that have differences if they have diabetes is more like the comorbidity, renal failure, and then if you perform it in the bifurcation lesion. And if you match it, it's still there's no difference between DEB and DES, but if you do it in the bifurcation lesion, the restenosis is much higher. So for DEB was not associated with increased MACE, all-cause death in 1 year, but worse outcome mainly due to clinical and or technical confounder. Overall similar clinical outcome can be achieved with both DCB or drug-eluting stent. And for comparison RCT between NISA Desire with comparing and paclitaxel coated balloon, plain balloon, paclitaxel coated balloon, and paclitaxel-eluting stent. Here we can see that I think in the first, in 10 years, the target lesion revascularization, I think, is better in paclitaxel coating balloon and also in eluting stent. But if you look the long term compared to balloon, so it's balloon is I think it's not an option. It's either a PCB or a drug-eluting stent. And then management of left main restenosis. This is a retrospective study from Huang from China, and I think this here it sees that if you compare between in unsuitable for CIBG, I think there is no difference between DCB and if you use DCB or DES. And even if you look, it's actually the syntax score is high, is around 43. And the Euro score actually is not that high, between 4 and 3. But if you see the true bifurcation, I think this is almost half of them are true bifurcation. And then it's diffuse ESR for both DCB and also DES. And if you look at the other study from the left main bifurcation, or most of them are retrospective study, I think there's only one study that shows a better outcome with DES, but the other three is the DCB is actually better, although it's not significant. And for clinical outcomes, based on the number of layer of metallic stent, can see if it's only the first time, I think the DCB will do as well as the second for the 2-layer stent. But when it comes to 3 layers, I think you should reconsider it because the restenosis is really high. It's almost 43%. And then if you compare between, I guess the other alternative, of course, cabbage. So if you, this only can get from the registry, from Dragon registry. If you compare to PCI between PCI and cabbage for treating restenosis, ESR in unprotected left main, you can see for the first 30-day follow-up, actually cardiac death is higher in the CABG. But in long term, target vessel revascularization is higher in the use of PCI. So for that, I think for left main ESR focus should focus on maintaining the balance between the long-term risk of target vessel revascularization and the perioperative complication of cabbage. However, PCI in left main ESR is oftentimes performed as a first-line saving treatment, especially when the patient is come in the acute setting. For the mechanism of the restenosis, I think it's very important to understand the mechanism so you won't get another to reduce the second restenosis after you intervene it. So imaging is, I think, is the key. First, we have to know whether it's due to stent under expansion or stent fracture, neo-intimal hyperplasia, or neo-atherosclerosis. I think both can do the job to differentiate between the mechanism of in-stent restenosis. If you use the Waxman in-stent restenosis classification, I think they divide it by 5. If there is a mechanical issue, then it should be correct the under expansion and then follow up with a stent. For biological, I think there's an option for balloon, DCB or DES. For neo-atherosclerosis, either fix the neo-atherosclerosis, dilate with maximal expansion, and then put a DES. And then for mixed pattern, I think the high pressure NC balloon and also either use DCB, DS, or brachytherapy. For CTO, maybe we should have a multiple layer. Maybe you should think about cabbage. For more than 2 layers, then, of course, as you mentioned, I think you should consider cabbage as you know that restenosis it will be very high. So the proposed mechanism and mechanical management of left main ESR is first, I think, before perform intravascular imaging, and it's to confirm whether it's functionally significant, and then perform the intravascular imaging. If it's the only 1 layer of stent, then confirm whether it's mechanical issue. If it's yes, of course, they have to address the mechanical issue and reassess again whether it is resolved. If it's resolved from intracoronary imaging, then you can, depends on the stent used previously. If it's BMS, which is probably, we don't see it anymore, then DCB, I think, is the first choice. But if it's not, then depending on what sort of imaging you get after your lesion preparation, then you decide whether you use DCB or DES. For multi-layer, I think the principle is the same. You have to prepare the lesion for the maximum expansion, and if it's already more than 2 layers, maybe you should consider cabbage. And the other thing, for the first intervention, if it's one-stent strategy, we probably can still use the 5, 6, 7 criteria. And for two-stent strategy, is the minimal is 6, 8, 10 criteria. It's even more important to do to get this result for the second time around. So the in-stent restenosis, what to do? Detect the stent-related mechanical problems, and then prepare the lesion well with all the device that you need depending on the anatomy. And DCB is preferred for focal ESR, first ESR episode, ESR with multiple metal layers. For recurrent and episode, a diffuse ESR, then we probably need a heart team discussion. DES would be preferred if it's suboptimal pre-dilatation result with residual greater than 50% and large dissection defined with a longitudinal extension more than 2 millimeter, large extension greater than 60-degree involvement of medial or adventitial, and then diffuse ESR, lost mechanical integrity, failed DCB strategy. And DCB is preferred, as mentioned before, focal ESR, first ESR episode, ESR and BMS, and multiple layers. The other thing is pharmacological management ESR is not only mechanical. I think there's some evidence that at least 24 months DAPT is associated with lower rates of death on MI, and lipid lowering therapy, more intense lipid lowering. As you know that higher the lipid when you do a PCI, there is a increased risk of early neoarteriosclerosis and restenosis. And PCSK9 has significantly reduced the risk of repeat revascularization due to ESR or stent thrombosis. And the take-home message is most evidence based on observational study and extrapolation of RCT in non-left main ESR. First, understand the mechanics. Second, prepare the lesion well. Aim for minimum expansion, especially when you proceed to DCB. And decision for DEB and DS should made post-optimal lesion preparation. And lastly, I think is for ESR in the left main, I think there's a prompt reflection on revascularization strategy that you have chosen. As guideline have recommended underscore that greater long-term benefit in CIBG, especially in extensive multifaceted disease, left main involvement with high in syntax score, diabetes, and reduced ejection fraction. Thank you very much.
Thank you very much for your excellent presentation. So before any question from the panelists, I have one question for you. Is in bifurcation in-stent restenosis, what's a factor guide your choice between DCB, repeat DS, or debulking the optimal trajectory and optimal trajectory for the in-stent restenosis?
Regarding the preparation?
Yeah.
Yeah, I guess it all depends on whether there is what's the cause of the restenosis, the mechanism. If the mechanism is under expansion due to calcification outside the stent, then probably your only choice would be IVL, or you do a atherectomy with a big burr, and then do pre-dilatation. And for the neoarteriosclerosis with calcification, I guess rotor ablation is an issue. But I think I missed one point here. Since you're doing a left main, I think the issue if we use DCB is long inflation. And I think before you decide to do DCB, I think you can use the balloon to see how the patient react or whether you actually need mechanical supporting hemodynamic to perform the procedure.
Yeah, thank you so much. Any comment from the panelists, please?
Excellent presentation, Duff. I guess we all have these patients who keep coming back every once in a while for repeat procedures, having had a small stent put in. And I'm just asking, so how, if it's a very old stent from several years ago, and the guy comes in, and of course no imaging was done previously, and now you've realized that it's massively undersized, how hard would you push it to get to those parameters that are specified there? Because sometimes it comes with a bigger risk as well with all the calcification.
I think in this case, I think IFUS would help because IFUS would see the adventitia and extraluminal lamina, and depending on how big of a chunk you have within the extralamina, then I would undersize the balloon.
I guess lifelong DAPT if it's severely undersized, or would you go for a shorter period?
Well, there's some evidence that at least for ESR, 24 month would reduce the risk of further ESR. But if it's undersized, I guess you would do it long life.
So, any more?